taken a thoughtful and evidence-based approach to thinking about medication management for folks, both early in the course of illnesses here and appreciating the nuances that come up there, but also thinking about recognizing folks beyond first episode or folks who are not responding to typical treatments here and how we can improve and better aim our care to support these individuals in their recovery. And today we'll get to hear about some of the exciting work that they and others have been reaching into to try and unpack more about Clozapine, this drug that is reserved for individuals who are not responding to other antipsychotic medications, that seems to offer some really life-changing benefits to individuals who haven't been able to benefit from other drugs here. But despite being the oldest of our second generation or atypical antipsychotics, is probably the one that we maybe appreciate or understand the least with regard to what this drug does and how it helps people in their recovery here. And today we'll get to hear a little bit more about that. Moving forward with today's talk, we will have a Q&A session at the end of the presentation with Dr. Stearns and Parris here. And questions can be submitted to me in the chat, and I'll relay that to them at the end. As always, closed captioning is available by clicking on the CC button at the bottom of the screen. And with that, I'm delighted to turn things over to two people that I feel very fortunate to consider my colleagues here, Walter Stearns and Craig Parris.
All right, thank you, Nick. Hi, everyone, I'm Walter. Craig's gonna take over in a little bit. We're gonna talk about clozapine and inflammation, but we're gonna start it off by giving a little bit of a preamble to that. Craig and I have no financial disclosures. And here's some learning objectives for the talk. First off, we're going to discuss the history of the development of antipsychotics. Some people might be familiar with this, but I think it's a good thing to go into. Talk about the discovery of clozapine and some of the positive clinical findings. Then we're going to go over potentially the role of inflammation in schizophrenia spectrum disorders. Learn a little bit about inflammation and clozapine specifically, and then look at a little bit of the studies looking at targeting inflammation in schizophrenia spectrum disorders. So here's a little brief history of treatment. And this is a quote I stole from a paper, which I thought was pretty relevant. It would be difficult to find many medical conditions that have been investigated with similar vigor and persistence over a century and have proved to be as intractable to understanding as schizophrenia. I think that's relevant because we don't understand schizophrenia well. It's probably the most complicated of all illnesses, and we have very little understanding of it. And I think our walking through the treatment history of it kind of shows that. So it was first really identified as a brain disease in the late 1800s by the German psychiatrist Emil Kraepelin. Before that, they've been recognized, psychosis had been recognized, but really seen as like a disease of the brain at that time. He separated into dementia praecox, which many people have heard of, versus manic depression, which would be bipolar disorder. In the early 1900s, Swiss psychiatrist Eugene Bleuler talked about schizophrenia, and he talked about it as having a biological component along with like a psychological component to it. And he said he was the first person to really say it was a group of diseases, not just one entity, which I think is something we'll carry forward, that what we see as schizophrenia spectrum disorders is probably multiple illnesses that we call schizophrenia, but it's probably very different etiologies, different kind of symptom domains, and possibly different treatments are required. In terms of treatments, we start off in the 19th century, before the advent of many treatments, and pretty much people would live in were the equivalent of like state hospitals, but live in asylums at the time, and they would be given sedatives, hypnotics, narcotics, mostly just to calm them, but they didn't really have any sort of therapeutic effect. In the early 1900s, they had the invention of barbiturates, which also were sedatives, which same kind of thing, sedative effect. In the 1930s, they were using lobotomy a lot. Actually, someone was given the Nobel Prize in 1949 Obviously, we see that as barbaric now, but you can just see kind of the evolution of how things have changed. Shock therapy was used in the early mid 1900s, 1933. They used insulin. They would put someone in insulin coma to induce a seizure. They would also give them drugs to make them have a seizure, like camphor. And shock therapy back then was fairly effective, and it's still effective. But now we'll use like ECT, electroconvulsive therapy. But back then they didn't have anesthetics. They didn't have muscle relaxants, so people would have seizures. And it was scary. And as a lot of the stigma with ECT is based on this kind of old portrayal of ECT. So again, at the time, there's no real medicines that do much of anything. The only thing which probably does something is ECT. All right, so in the 1930s and 1940s, the pharmaceutical companies had a great interest in developing antihistamines. They saw it as a good market to develop antihistamines. And so they started making all sorts of antihistamines. And in 1950, they developed RP 4560, which would eventually be known as, which was chlorpromazine, which would eventually be known as Thorazine. And back then, when drug companies would market a drug, they didn't have big like phase 1, phase 2, phase 3 trials. They would kind of go around to local doctors and ask them to use it. And really the story, whether or not it's true or not, is that there was a French surgeon who would use chlorpromazine to give it to patients before surgery to help with their anxiety. And he said it was really good. It had a very strong calming effect. And he had a couple of friends, French psychiatrists who worked in the asylums at the time. And he said, you should try this medicine because I know sometimes the patients there are agitated. And they tried it and they saw that it helped. Not only helped calm, but it seemed to help some of the patients with some of their psychotic symptoms. And that was the beginning of Thorazine. It got FDA approval in 1954, but we have to remember FDA approval back then wasn't as rigorous as it is now. And at that time, that Thorazine was the first typical antipsychotic, and numerous other antipsychotics came about after that of the typical agents, what we call the typical agents. This was an interesting ad, I just found on Wikipedia, advertising for Thorazine. It kind of shows you the view of almost how they treated mental health back then. You can read it. When the patient lashes out against them, Thorazine quickly puts an end to his violent outburst. It's not a very therapeutic ad. It's more just like, we need something to calm someone to help it. But you kind of see the view of what they thought of patients in that time, people with schizophrenia, as kind of almost inhuman aspect to it. And that's kind of, the current stigma, you still see residual from those times and kind of how it was viewed. And this ad, I think, highlights that quite well. So this also was the beginning of the dopamine hypothesis. So when we think of schizophrenia, we think about like, what causes this? What treats this? And they saw that Thorazine blocked dopamine receptors, actually the D2 receptors in the brain. And they also saw that if you give someone amphetamine, which releases dopamine, you can produce a psychotic state. So this was kind of their idea of like, this is what schizophrenia is. So it wasn't as though they came up with these ideas beforehand and tested it out. This is how these drugs work, and we're going to work backwards to figure out what caused the illness. And as you can see, that's an interesting way to go about it. That's a lot of how medicine works, but it doesn't really have a lot of like sound basis in like the understanding the true etiology of things. So this is the beginning of the dopamine hypothesis, saying that excess dopamine causes positive symptoms. The negative and cognitive symptoms of the illness and the mood symptoms, maybe it's because of too little dopamine. Again, this is just speculation, but that's where the dopamine hypothesis that you hear about, it kind of stands now. And again, it's just, we don't understand schizophrenia. This is how the drug works. So this is how then the illness works. And you could, on the face value of that, you can see that that's already questionable. But we'll move forward. Clozapine came about. So clozapine was synthesized in 1958, still in the 50s. Originally thought to be an antidepressant, but they saw that it had some antipsychotic effect. But what was interesting about it is that it didn't cause a lot of motor symptoms. So a lot of the drugs that block dopamine cause movement issues, motor issues, because in essence, you're Parkinsonizing someone. You're blocking their dopamine, you're blocking their motor pathways. But clozapine didn't really do it that much. And so with that, they termed it the atypical antipsychotic. The first one that didn't cause these kind of motor symptoms, so hence atypical. Entered the market in 1971, was pulled from the market. This is a European market, pulled from the market in 1975 because 8 people died. So the company got scared, people got scared, they pulled it from the market. They're saying, we don't know what's going on. They eventually find out it dropped their immune cells, their neutrophils, and that's the cause of death. Is they were susceptible to infection. So clozapine's kind of on the back burner. Other typical drugs are coming about, things like Haldol, stelazine, things of that nature. But what they were seeing though is that two things. They were seeing with the use of these typical drugs that all bind dopamine quite tightly, even though clozapine binds dopamine just not that tight, not nearly as tightly as other ones. With the blocking of dopamine, that they would see these movement issues. If you're on a dopamine blocking drug, especially at high dosing, it can cause a host of movement issues. And with that, people can develop tardive dyskinesia, which is long-term movement issues, involuntary movement issues. So they saw that the longer people were on drugs, the medicines, that this became more of an issue. And they're like thinking back, like, well, clozapine didn't really cause a lot of this dopamine blockade, these motor issues. Maybe we should start thinking about this drug again. And they also were speculating that, they remember clozapine might have worked a little better than the other drugs. And what they were seeing was the dopamine blocking drugs, the thorazines, the Haldols, they weren't helping everyone. There was a subset of people, maybe about 30% of people who those drugs didn't really do much for. And those people would they would have to stay in the hospital. They're chronically very sick. So they were beginning to say like, maybe we need something else. So what happened is there's what Sandoz, the drug company, which eventually become Novartis, talked to the FDA, the US FDA, and they said, we have interest in pursuing clozapine again. And they talked to the FDA, and the FDA is like, well, if this drug is dangerous, you have a bunch of other drugs. This drug is dangerous. We don't really want it on the market. So they said, what we'll do? Maybe we'll see if we can show that it's more effective in people with treatment refractory schizophrenia, people who've been on other medicines and they haven't worked. If we can, in essence, the idea of like an orphan drug. We'll see that nowadays. If this is a patient population who there's no current treatment, sometimes if you can get FDA approval by saying like nothing else is working. We can, if we can put some safety things in place, if we can show efficacy, we can get FDA approval. And so that's what they did. They went, and I'll show you on the next slide. They went for drug approval using clozapine for treatment refractory schizophrenia for people who had been sick for a long time, generally years they've been sick for, living in state hospitals for many, many months. And they showed that it was effective. What they did though is they mandated mandatory blood draws. And this is something you've heard about clozapine with the dropping of the neutrophils, but you had to get blood draws every week for the first 6 months, and they would get spaced out in order to minimize the risk of people developing this immune system problem. And so clozapine got approval in 1990 for treatment refractory schizophrenia. After that, in 1993 was the beginning of all the other atypical drugs came about. Risperidone was the first one that came about, then olanzapine, and so on and so forth. And really what the atypical drugs were, they were seen to not block dopamine as tightly, kind of like clozapine, maybe block serotonin a little bit more. And really what they would do is they were designed to be like clozapine, and they were marketed for many years as almost as good as clozapine without this kind of dangerous side effect profile. So that was the beginning. So clozapine, as Nick had mentioned, was the first of the atypical drugs. So quickly, this was just a study that got an approval, the Kane trial. And really what it did, it took people who had treatment refractory schizophrenia. So they got people, had been sick for a long time, many years in the state hospitals. And they said, we're going to put you on clozapine or thorazine to see which one works better. But cleverly, Dr. Kane said, first, we'll read people's charts, we'll read histories, but I want to make sure before my eyes that this is a truly treatment refractory group. So we did a lead in with Haldol to make sure that they were sick. And anyone who is still on Haldol, was on Haldol, didn't show improvement, was then put on clozapine or thorazine. And really what you see here, let's see if I can use the laser pointer, you can see here, the solid line is clozapine, the dashed line is thorazine. You see clozapine quickly start separating from thorazine. And you see that about 30% of the people in the clozapine group responded well versus only 4% of the thorazine group. And this study, these types of numbers have been replicated pretty consistently. So this was the first time you see that clozapine is doing something other drugs aren't. Clozapine is blocking dopamine as the other drugs are, but it's doing something else. What it is, we don't know, but it's doing something else. So it begins to speak to the fact that like clozapine has some other sort of mechanism that's working. But remember, this is a very older, sicker patient group who's been in the hospital and sick for years and years and years. Another trial looking at clozapine was looking at clozapine for suicide. with the thought that clozapine was a better drug, they said, you know what, let's look at it for suicide. So what they did is they took clozapine, put it up against olanzapine, which is another very good drug, most commonly used drug in the US at the time, in a high-risk patient group up for suicide who are having command hallucinations, recent suicide attempts. And they took people who, they didn't take a group that was all refractory, because that wouldn't have been fair, because then clozapine would have had an advantage. And they put them up against olanzapine. And what you see here is that clozapine's a solid line, olanzapine's a dashed line, and clozapine did better in terms of suicidal behavior and events. And so clozapine is the only drug that has any indication for anti-suicide effect in schizophrenia or schizoaffective disorder. So again, you're seeing that clozapine is doing something. There's something else about it. Why is it conferring this anti-suicide effect? It's not purely that it helps just like the refractory symptoms. It was doing it in people who weren't refractory. It's doing something else. But again, we don't know what that is. This is a big trial. You guys might have heard of the Katie trial, which is another trial looking at people with chronic schizophrenia, people who've been sick for many years. The big NIMH sponsored trial, where this is what they did is they took people and put them on the typical antipsychotics, Geodon, Seroquel, Zyprexa, Risperdal, and they put them up against an older drug, perfenazine, Trilofan, first generation drug, to see if any of them were better. They took patients who were not first episode, they took patients who were not treatment refractory, and they put them on those drugs and saw how they did. And what they saw is that they were pretty comparable. Olanzapine might have done better. But then the people who didn't respond there, they said, all right, there's a group of those people who didn't respond. They put them in this trial here. And you can see this trial here. And what they did is they said, we're going to put you on clozapine, olanzapine, Seroquel, or risperidone, and we're going to see how you do. And when you see the green line, what they use as an effectiveness measure is discontinuation. You see the green line shows that clozapine is better if people stop the medicine less than the other medicines, and especially for lack of efficacy. So again, in the biggest schizophrenia trial that's been done, clozapine again shows that it's probably still the best in terms of how well it works, but especially in a treatment refractory group, as this kind of study showed. And also, but again, also in a chronic group, in a group that's been sick for a long time. Okay. One last thing about clozapine is that, people were worried about clozapine, and Craig will get into some of the concerns people had, but people were worried about it. We have to get weekly lab work, and you're worried about your immune cells and other things you're going to worry about. So what this study looked at was a cohort of people in Finland who'd been and tracking them for a long time to see the risk of death. It's hard to look at death is relatively, rare to look at. It's hard to look at in a randomized controlled trial. So a lot of times you have to track people for a long time. So this study tracked people for 11 years, in essence, and they saw what drugs they were on and their risk of death. And really what you see in figure A here, this risk of death from any cause, on the left is clozapine, and the risk is lower than 1, which is what they standardized it to perfenazine, Trilofan, the drug they used in the Katie trial. You see clozapine does better. So clozapine has like the best mortality of all the antipsychotics. So again, this drug that people are scared of, that is doing something, possibly dangerous with the immune cells and other things, people live the longest on it. So it's doing something. It's treating whatever it's doing. It's treating the illness better. Why it's doing that, we don't know. It blocks dopamine like all the other drugs, but there's probably some other thing that it does, but we don't understand it. This is just a quick thing on the timeline. You see clozapine, how old it is. Discovered 1958, right near Thorazine. Modern day, 2022, still the best drug. And you just see how things haven't changed. It goes back to the idea that we don't understand these illnesses. Think about the advances in cancer and cardiology, compared to the late 50s. I mean, huge advances. But for mental health, for schizophrenia, spectrum disorders, clozapine is still the best. So it just kind of highlights that we don't know what we're doing, like sadly enough. But that's what we're trying to figure out. So with this, you're seeing the concerns that it's not just dopamine blockade. Okay, if it was pure dopamine blockade, there has to be something else, or other things are involved, because a lot of patients, on these drugs, they don't get better, but clozapine works better, but it doesn't block dopamine. So some other hypotheses came out. There's a glutamate hypothesis of schizophrenia, pretty much saying that if you give someone PCP, which can block the NMDA receptor, which is a glutamate receptor, you can mimic the symptoms of schizophrenia. So the idea was that maybe there's a deficiency in glutamate. It's possible, it's possible this is related to this, but really what it is, it's like searching. It's searching for hypotheses, searching for neurotransmitter hypotheses. We like the neurotransmitters in mental health because it simplifies things. but the brain probably isn't that simple. So as of right now, the glutamate hypothesis hasn't really gone anywhere that's substantial. So right now, no FDA-approved antipsychotic has shown efficacy which doesn't have some D2 receptor effects. Okay, so that speaks to something, we haven't really advanced that far since the 50s. So that's a concern about the dopamine blockade and the pure dopamine, and that this is the answer. They're also seeing, with time that when they looked at MRI, like initially CAT scans and MRIs of brains of people with schizophrenia spectrum disorders, you were seeing changes, brain changes. You were seeing, gray matter reductions in multiple areas. You were seeing the white matter tracks, which are kind of like the highways connecting the hubs in the brain. You were seeing them kind of like the highways had like potholes in essence, the frayed white matter tracks. So you were seeing some degree of like brain destruction. So when you see that, you're saying like it's not just as simple as a neurotransmitter being high or low. There's something going on. This sounds like a process is going on. Something's happening. And the more you look at this, the more you can think of the different domains of the illness. So when we think of the schizophrenia spectrum illness, we think of positive symptoms, the hallucinations, the delusions, but there's also marked negative symptoms and cognitive symptoms which come to play, and they're a big part of the illness. What do the medicines treat? Well, the medicines, when you look at it in studies that are mostly looking at more chronic patients, they mostly treat the positive symptoms. So on the left here is all the symptoms, positive and negative. And on the right's the positive. What you're seeing is that these are very similar looking curves because mostly the medicines are treating the positive symptoms. But these negative and cognitive symptoms, the medicines don't really treat. So in essence, the medicine is doing something, but there's still a lot of problems that remain, deficits that remain. And so something's causing it. It's not just a neurotransmitter. It's something that's causing this. So what would happen if you treated someone early? This idea of treating people who've been sick for a long time, if this is some process going on, this whatever it is, inflammatory process, whatever it is, you would think maybe treating someone early, maybe you're catching it earlier. If you catch it earlier, what happens then? Would people do better? And so there's some speculation about this, and this was the RAISE trial, famous trial, first episode psychosis, looking at people who were treated with like an intensive intervention, which is what they call the NAVIGATE, the NAV group, which is like the CSC, the coordinated specialty care you see with first episode, which is kind of the hallmark first episode care, or just regular community care. And the idea is that what RAISE showed is that if you treat someone with what they call a DUP, a duration of untreated psychosis, if you treat them earlier, they tend to do better. So we'll look at the PAN score, the one on the right. The groups in the solid lines are the people who had the duration of untreated psychosis that was shorter, less than the 74 weeks. And what you see is they start off a little less symptomatic, but they have a much better trajectory. They do better and much improved like reduction in scores. And what you can see on the left, the quality of life, is you can see the ones who have with the solid line, which is the shorter duration of untreated psychosis, they tend to do better, but they tend to do better with really intensive intervention. So it's as though you see someone like they've been sick for less long, you impart this like highly specialized, like highly intense intervention, and they can do very well. They can do very well. To me, when you see that, you're like, well, maybe you're catching something earlier. You're catching it earlier, the idea of early intervention, and maybe you're stopping the progress of something. There's been some debate in the community, though, about whether or not, maybe you're just catching something earlier, but this is just, what they call lead time bias. You catch them early, but like if you track it down 10, 15, 20 years, it all ends up the same. So they've looked at this a little bit. This was a study looking at people who are treated for 20 years, up to 20 years. And again, they weren't necessarily always in treatment, always on medication, but really treating someone early, does it help things? So we look at this figure in the top left. They have the different groupings of DUP, duration of untreated psychosis. And the group in blue has the shortest duration of untreated psychosis. And the group in orange has the longest. And what you see in terms of scores is the group who had the shortest duration had the best kind of outcome in terms of scores, in terms of different kind of scales. To me, that sounds like a couple things can happen. Maybe the people who have a duration of untreated psychosis that is shorter, maybe they have a different illness. Maybe they have one that's more treatable, and as you see, they have fewer negative symptoms here. But maybe it's that you're catching someone earlier, for some subset of people. If we're going to consider schizophrenia a wide swath of illnesses, for some subset of people, maybe catching them early, you're stopping a process. There's a process going on that you're stopping by treating. What that process is the question. This was an interesting study that I think kind of highlights this. So this took people with patient population with schizophrenia, and these are just rating scale scores on the left, and they treated them with a medication. And you see episode 1, you see the group starts off symptomatic, has a pretty quick drop in symptoms, and over the course of a year does well. And then they follow this group, and the people who got sick again, generally because they're non-adherent, they put them back on the same medicine, and they wanted to see how they did on the same medicine. And what they saw is that the group episode 2, they don't do as well. It takes longer to get better, and they don't get as well. So it's almost as though this process is going on. You put a stop to this process, and then you pull the brakes off, so adherence stops, and then you put the medicine back on. But something happened in between. To me, that sounds like a progression of something. Something is going on. Something is progressing. This thing isn't static. This is a slide that is in a number of studies that we'll use, but I just want to highlight, makes me always think about, this onset and progression. You have this kind of slow decrease in deterioration of psychotic symptoms, and with that, you'll have the positive symptoms, you'll have the negative symptoms, you'll have the cognitive symptoms. And in this red area, this deterioration, is this something going on that we can stop? And my speculation is that for some people, this is a process that you can stop, and treatment maybe tends to stop it. Why is that? Well, you see, if you treat it, with medicine, whatever the medicine's doing, you treat it, you see the positive symptoms tend to be less. There's also literature that people with a shorter duration of untreated psychosis have less negative symptoms. They also tend to have less cognitive symptoms. So to me, there's some process going on, at least for some people, that you're putting a stop to by giving them treatment. So while this is all going on, the understanding of schizophrenia is kind of changing. So we're realizing that schizophrenia, from a lot of twin studies, it's a very strong genetic component, very strong heritability, 70-80%. But that means it's not set in stone. Okay, so if it's 78% heritability, it means that you can have some high probability of having it, but it doesn't mean you're guaranteed to have it. So that means there's something else maybe pushing it. They started looking at, they realized there's no schizophrenia gene. There's no single gene that causes it that everyone would have. And that kind of makes sense, because if there was a schizophrenia gene, it would probably be strongly selected against for evolutionary pressure, because it has been shown to have a decreased reproductive fecundity, ability to have children. And so it makes sense that it's not a single gene. So what they did when they looked at these, what are GWAS studies, looking at all the risk alleles for all sorts of things, they saw that there's thousands of risk alleles that confer a little bit of risk. So, and the risk alleles can be anywhere, and alleles are just kind of genetic variations in the genome that are common for everyone, like eye color, for example, like blue, brown, things like that. So what they're seeing is that there's many genes that can confer some risk to schizophrenia across a wide array of the genome. A lot of them are related to genes in the neurons and expressed in the brain. Also, some of them are related to the genes in the immune system, and so you see that, you're like, all right, what's going on? You have some genetic loading. There's all sorts of ways to kind of have some genetic loading. It's not guaranteed you're going to get the illness, but it leaves you somewhat susceptible. And they talk about polygenic risk scores, which are ways to kind of add up the number of risk alleles you have. And the higher your polygenic risk score is, probably the more likelihood you have of developing a schizophrenia spectrum illness, psychotic illness. So you're beginning to see this, and you're saying all right, this speaks to a wide variety of different illnesses that we're dealing with, and kind of leaving you more or less susceptible to getting it. But something, you also think something might, what is it that might push it? Your genetics isn't necessarily guaranteed as to what's going to happen. Something might need to push it. And so you say to yourself, this is a progress, this is a process that's going on, that you're set up genetically for, some people more, some people less. What's pushing it? And it seems like there's some inflammatory component with kind of some of the brain destruction, with the white matter and gray matter, some of the cognitive worsening, the negative symptoms, and the worsening illness. So what's pushing it? So there's been more interest in the immune system. So talking about the genetics, we saw that some of the genetic risk alleles are related to the MHC system, which is very much involved in kind of your immune response and how you kind of mount that, but also the complement system, which is very much involved in immune response, also has a lot to do with the pruning of the synapses when people in adolescence, when there's a large synaptic pruning. So they're like, oh, that's interesting, that some of the genetics is tied into risk for schizophrenia. It's also been a known thing that, infection, maternal infection probably increases the risk of psychosis. And you think about that, like, what does it do? Does it kind of take the immune system and just kind of like move it a little bit, you have your genetics, the natural genetics, and just moves it a little bit, kind of increases that risk. What about childhood abuse? Abuse in any manner, sexual, physical, emotional, bullying, various things. If you think about it with a child, takes the immune system, takes the, HBA stress system, and just kind of moves it a little bit too. It might be that additional stressor that you need. If you look at encephalitis, which is inflammation of the brain, if you have inflammation of the brain, you can get psychotic. So autoimmune encephalitis is one of the things that we see, and you get the various ways to have it. But you can get psychotic. So it's just like actual localized inflammation can cause psychosis. And even COVID, there are cases people have COVID causing psychosis. And you see that, you're like, well, why would that be? And you're like, well, if there's some inflammatory component to what's going on, it makes sense that sometimes this will be the cause, and this will be the result of it. Dementia, another thing, what is dementia? Dementia is a wide variety of things, but there's a big tie-in for inflammation causing it. People with severe mental illness get dementia much, much earlier. Some of that is thought because, more substance use, decreased interest, decreased ability to take care of their physical health, higher cigarette smoking. But even taking that into account, you can see that dementia starts much earlier. So again, like, it speaks a little bit to some more of an inflammatory hypothesis with what's going on. One of the things I always think is interesting is the autoimmune aspect. So autoimmune, obviously, there's some immune component, attacking yourself in essence. So is there a linkage with psychotic illnesses and autoimmune illnesses? If you look at MS and look at lupus, they definitely have higher frequencies of neuropsychiatric problems, including psychosis. So you're kind of like, yeah, so inflammation kind of the brain can kind of cause psychosis. Some people with certain autoimmune diseases, psoriasis, autoimmune hepatitis, type 1 diabetes, have increased risk of schizophrenia. So again, you're kind of saying like, all right, why is that? What's going on? Is it a genetic thing you see appears, and is it an infection thing? Is there some dysregulation of the immune system that kind of like puts you at risk for both these things? We don't know, but there is some tie-in. It's some, some clear correlational aspect to these things. People with autoimmune disorders also have an increase of psychotic disorders and vice versa. So again, you're just seeing a tie-in with the immune system and what's going on. So you begin to wonder, like, is the immune system for some people with schizophrenia spectrum illnesses, is this kind of the thing that's going on? Like it just has moved in a little bit, like a little subtle change. It's kind of that push that kind of pushes the system. We don't know, but it's part of the speculation. Couple last things, and I'll let Craig take over. Cannabis, cannabis has been shown to kind of increase the risk of psychosis. It's pretty consistently shown. This is a slide showing that, a meta-analysis showing that. But the question is why? What does it do? And there's a lot of theories on what it does. But one of the theories is that, like, cannabis, especially alpha-9 THC, which is the psychoactive component, pushes on the system. It has some pro-inflammatory component that might push on it. And if you think about someone with, you'll think about the genetics, and they have some susceptibility to it, and the cannabis just kind of pushes that over a little bit. But then cannabidiol probably doesn't. Cannabidiol might have a antipsychotic effect. So why is that? Well, cannabidiol very well might have some anti-inflammatory effect. So kind of like decreasing your risk of this kind of thing happening, a la an antipsychotic. One last thing is that the role of estrogen. So if you look at the picture on the right, this is the incidence of psychotic disorders in men and women. So men are more likely to get psychotic disorders than women. It's probably about a 1.2 to 1.3 to 1 ratio. And men tend to get it earlier. So the men are in blue, the women are in orange. And what you see is the men tend to get it earlier, and it just kind of drops down with time. And the women are less likely to get it early, and it's more of a flat line. So why would that be? And there's some thought that estrogen itself has some anti-inflammatory components, and it's somewhat neuroprotective, that kind of makes it so it's harder to push over, harder to get the kind of push over to developing a psychotic disorder. What is interesting, if you look at this, actually the orange line, if you look at this little blip up where the women actually go over men, this is around like premenopausal, menopausal time when they might lose an estrogen protection. And it kind of fits into that kind of model that it's providing some sort of protection in that regard. All right, so now I will let Craig take over. He will slide into the chair. So thank you. There you go. So, so getting back to clozapine specifically, Walter pretty well answered this question. Why is clozapine important? It's effective when other antipsychotics aren't. It's also consistently and extensively recommended as a third-line agent and can be used earlier because of its efficacy with safety or with violence risk. Treatment refractory schizophrenia affects 20 to 30% of patients, and clozapine remains the gold standard for this group, with response rates of up to 40% in people who wouldn't respond to other antipsychotics well. It's also been demonstrated that clozapine has a higher response rate when you get it to the people that need it earlier in the course of illness, providing maybe another example of its ability to like halt some kind of pathological process. In looking at this, an investigation of 105 individuals found that people started on clozapine less than 2.8 years into their illness onset had a response rate of 82%, whereas the response rates were 31% in those beyond that period of time, which is a critical duration of untreated psychosis window similar to that seen in first episode psychosis. A more important question might be to ask, why not clozapine? The rates of clozapine use in the United States are around 5% of total patients with schizophrenia, when at least 20% of those individuals are eligible for a clozapine trial and for treatment. It's often not utilized despite treatment recommendations due to various areas of biases and deficits in support, both on an inpatient and outpatient basis. The number one reason cited by providers for not using it is a lack of knowledge and training regarding its use, with the second reason being its concern for side effects, of which we'll talk about the many that there are. It's well established that schizophrenia by itself can be associated with excess mortality and physical comorbidity, with a reduction in life expectancy of 14 and a half years compared to the general population. As Walter mentioned, like this disproportionate mortality is often, ascribed to poor health habits and medication side effects, as well as lack of engagement with the healthcare system. But it's important to note that an increased incidence of somatic illness is present preceding a psychotic diagnosis, which suggests a multisystemic process rather than a disease isolated to the mind and the consequences of that illness. The safety of long-term treatment with antipsychotics has also been called into question, primarily due to risk for weight gain and dyslipidemia, metabolic syndrome, which can contribute to higher cardiovascular issues and death. And to investigate this, as a follow-up of the 11-year study that Walter mentioned, there was a 20-year follow-up, which again, showed that clozapine, pretty well outperformed most other treatments, despite being considered a somewhat dangerous treatment. It showed that any form of antipsychotic treatment was associated with a lower all-cause and cardiovascular and suicide mortality, but clozapine kind of up here as the third performing agent is behind only long-acting injectable olanzapine, which is rarely used due to the monitoring requirements, and oral flupentixol, which isn't available in the United States. I'll kind of skip over this a bit. As was mentioned, clozapine's pretty well known for agranulocytosis, as that was kind of the reason it was pulled from the market and why it requires such significant monitoring for use still today. It should be noted that kind of despite the notoriety for this risk, the risk of clozapine-induced agranulocytosis is pretty low, estimated to be around 0.68% in the first year of treatment, after which it drops by a factor of 10. The mortality associated with it when it does occur is estimated to be around 3%, and an absolute mortality of agranulocytosis in individuals treated with clozapine is much, much lower at about 0.02%. 2017 review of 25 years of genetic investigations into clozapine-induced agranulocytosis included studies ranging from gene studies to genome-wide analysis, and concluded it's most likely a complex polygenic trait involving the human leukocyte antigen. It's really still unclear why there's an increased incidence associated with clozapine, but there's some speculation that it's due to the potential for it to produce ions that are similarly produced by chemical carcinogens. There was also a very recent study published from Finland, including 516 patients, that found that long-term clozapine use was associated with an increased risk for hematologic malignancies. Though the authors in this article made a point of acknowledging that the risk of such malignancies is still very low, and that it's much, much less than the risk reduction in all-cause mortality with clozapine use. But that's not all. It's not just agranulocytosis that can be kind of a scary product of clozapine use. Over now decades of prescribing clozapine, it's been associated with a number of unique side effects, which also kind of suggest an interaction with the immune and inflammatory systems. These side effects include fever, myocarditis, which we'll talk about more in detail coming up, interstitial nephritis, serositis, Dress syndrome, paralytic ileus, myositis, and hepatitis. Most of these side effects, with the exception of ileus, predominantly present within the first month or so after initiation of treatment, and almost always within the first year. They also typically occur during someone's first trial of clozapine. An association between clozapine and myocarditis, potentially life-threatening inflammation of the heart muscle, was first noted in 1999. This was also published in Lancet, and it used data from 23 cases in Australia. As is the case with the other side effects associated with it, a large portion typically occur within the first 3 weeks, with about 87% of cases occurring within 30 days. The subtle and varying clinical presentations make it somewhat difficult to determine the true incidence of clozapine myocarditis, though most studies suggest a range between 0.2 and 3.4%, with higher rates reported in areas where they're looking for it more. The figure at the bottom is a proposed typical timeline for the evolution of clozapine-induced myocarditis, and it was published by Ronaldson et al. In 2011, along with their monitoring protocol, which is included on this slide here. The protocol was made based on 75 cases and recommends monitoring for signs of inflammation using CRP, as well as cardiac damage using troponin weekly for the first 4 to 6 weeks of treatment, with stipulations to look more frequently when and if abnormalities occur. Despite these recommendations being made 11 years ago, as well as increased awareness and monitoring for clozapine cardiac toxicities, there's still no consensus guidelines available for monitoring, as well as no recommendations for what to do when and if these kinds of things occur. At OSU, we've kind of adopted a similar protocol for monitoring. There are some variations kind of noted in the table. We generally are in agreement that CRP greater than 100 or troponin greater than 2 upper limits of normal warrants consideration for discontinuation, and at minimum, definite investigation into like structural imaging of the heart. Usually, any kind of like abnormality will result in an investigation with an echocardiogram or a cardiac MRI, and through collaboration with cardiology, there is no specific time in which we've an agreed upon point at which to stop the medication, which we'll kind of talk about a little bit more. The decision to actually stop versus continuing the treatment in the setting of abnormal labs is pretty complex. Most patients treated with clozapine have failed to respond to a number of other treatments, and so clozapine itself kind of represents a last opportunity for symptom control. So choosing to discontinue that kind of an option can represent significant loss. Presently, in the setting of CRP and troponin abnormality, the few available recommendations will strongly recommend cessation of the medication. Something that these kind of recommendations don't take into account are the potential for transient symptoms that could resolve with cautious continuation of treatment, and supportive care measures like increased vital signs, increased laboratory monitoring, heart rate control with addition of a beta blocker, and dose reduction of clozapine or pausing of the titration. Kind of in our own monitoring through kind of the measures outlined in the previous slide, we've identified instances of CRP and troponin abnormalities that are transient, and in checking cardiac imaging on those kinds of individuals, usually primarily echocardiogram, there wasn't significant evidence of cardiac dysfunction, which would require discontinuation. And that is kind of further supported by instances where myocarditis was confirmed with MRI, though the patients were able to continue on treatment, with a couple of cases being recently published by people at OSU, one of which is included in this presentation. The variety of presentations associated with like inflammatory markers in myocarditis, as well as the other unique side effects seen with clozapine, kind of let us question what is the etiology of this? Why are these like hosts of side effects and symptoms seen pretty much only with clozapine? And though it's still kind of something that we're investigating, we've pulled EMR data from the past 8 years for statistical analysis of these kinds of things. Unfortunately, we weren't able to kind of get that process done by the time of this presentation. So maybe a future presentation, we can talk about that. We hope with that kind of information, we'll be able to better predict patients that may develop myocarditis, that may develop some kind of inflammatory response, but also predict patients that may have more of a transient response and be able to continue the medication. There are some known variables that can contribute to an increased risk for inflammatory response, as well as myocarditis during an initial titration. And one of those risk factors that's been consistently reported is the rate of dose titration, which can be impacted by genetic variations in clozapine metabolism as well. An example of this is individuals with Asian or Native American ancestry who have lower CYP1A2 activity, and as a result of that require a slower titration of the medication as well as lower dosing. Utilizing a standard titration on these kinds of individuals can result in an inflammatory response and can also lead to myocarditis. Systemic inflammation in itself releases different cytokines, immune system markers that can inhibit CYP1A2 activity and can lead to increased clozapine levels, including toxicity. This can be especially important in patients treated with clozapine as they're at a higher risk for pneumonia. It's also something that was noted fairly early on in the pandemic, as individuals with COVID-19 were found to have toxicity as a result of inhibited metabolism. And there's also been even rare reports of increased clozapine levels associated with COVID vaccination. During periods of illness, it's recommended consideration for dose reduction with the potential need to reduce the dose by up to 3-fold because of inhibited metabolism. And as mentioned in the previous slide, rapid clozapine titration can also induce inflammation, which leads to inhibited CYP1A2 activity and then decreases clozapine, kind of creating a positive feedback of inflammation and toxicity in the setting of this kind of thing. Monitoring for CRP during an initial titration is not only helpful for monitoring for potential myocarditis specifically, but it also can be an indicator that a titration might be too fast for a particular patient. Fairly new guidelines suggest pausing a titration with elevation of CRP. I think the recommendation was around 30, and more frequent CRP monitoring with consideration of dose reduction if the labs don't normalize in the following days. So repeatedly seeing these, transient inflammatory responses, these cases of myocarditis, had us and looking into, why are these side effects occurring? Has anyone investigated why these side effects are occurring? We kept asking ourselves, is there something to these unique side effects that's also kind of a window into why clozapine is uniquely efficacious when other medications aren't? Is clozapine's interaction with the immune or inflammatory system part of why it works when other antipsychotics fail? There's limited and mixed data identifying specific immune system abnormalities characterized by cytokine alterations in different disease states of psychotic illness. The figure on the right details effect sizes for levels of cytokines in acute relapse, which is represented by the red bars, versus drug-naive first episode psychosis patients, represented by the blue bars. For acute relapse and first episode psychosis, positive effect sizes, which are the bars heading to the right, indicated that levels were higher in schizophrenia than control subjects, whereas negative effect sizes going to the left were an indication that they were higher in controls. You can see that for IL-6, which we'll discuss more soon, TNF-alpha, TGF-beta, IFN-gamma, and IL-2, effect sizes
were very similar for both acute relapse and first episode patients. The green bar represents a change in individual cytokines following antipsychotic treatment for an acute illness, exacerbation. Positive effect sizes indicate that the levels increase following antipsychotic treatment, whereas negative effect sizes were representative of levels decreasing following antipsychotic treatment, which tended to be the case for most. The most consistent signal seen with schizophrenia involves the cytokine IL-6, which is elevated in acute exacerbation, both in a first episode and more chronic patient. Some elevation is also seen in individuals at clinical high risk for psychosis. The figure at the bottom is a meta-analysis of IL-6 comparing schizophrenia groups versus healthy controls, which showed that at baseline, serum IL-6 in the schizophrenia group was higher. The top right figure is a forest plot showing effect sizes for different immune parameters in antipsychotic naive first episode patients, which noted significant elevation in various immune markers, which include IL-6. There's been a hypothesized an immune subgroup of psychosis, though there can be made the argument that kind of an absence of variability in the elevations of various immune parameters versus controls are more of an evidence toward like specific immune abnormalities associated with a psychotic state, more of specifically more of IL-6, the lack of IL-6 variability representing a core component or like a more uniformly present component of the immunobiology of psychosis. This is somewhat complicated by the numerous functions of IL-6, which include inflammation and acute phase response, immune response, hematopoiesis, glucose and lipid metabolism, and bone turnover. IL-6 levels do correlate with a response or lack of response to antipsychotic treatment. The top figure comes from the same systematic review, and it's a meta-analysis of IL-6 in individuals with schizophrenia both before and after treatment, and demonstrated an overall reduction in IL-6 following treatment. The bottom right table is a study measuring different immune markers at baseline 2 and 4 months in normal controls versus responders to treatment versus non-responders. And what it showed is kind of an elevation of IL-6 in individuals with persistent elevation of IL-6 and those that didn't respond. IL-6 has also been positively correlated with improvement in positive symptoms, which is represented in the bottom left figure. So there continues to be an evolving literature base which demonstrates changes in numerous cytokines in response to treatment. Clozapine, unfortunately, hasn't been investigated in very much depth, seemingly as it fell out of favor clinically and in the research setting. And the few studies that tend to look at this are fairly old and provide somewhat mixed signals. There are several in vitro studies which examine clozapine's effect on cytokines in cell cultures. One of these was from 2011 and evaluated the addition of antipsychotics to blood samples obtained from 10 healthy individuals who were given a toxic shock syndrome stimulant to induce inflammation. The study demonstrated a stimulatory effect on IL-17 from clozapine and its metabolite, which is significant as IL-17 has anti-inflammatory properties. Another in vitro study from 2000 reported on clozapine increasing IL-1 receptor antagonist action, which is an antagonist of the pro-inflammatory cytokine IL-1, and also again suggests an anti-inflammatory action of the medication. It's, as I mentioned before, the limited studies looking at clozapine kind of do offer mixed results, and there's actually been some evidence of an initial short-term increase in IL-6 with addition of clozapine, which may be associated with its transient fever and other side effects. There's also demonstrated an initial increase in CRP following treatment, which tends to fade with time and is associated with improvement in TNF alpha if given enough time on clozapine treatment. So the question remains, does clozapine impact the immune system in some uniquely therapeutic way? Given the substantial evidence for immune abnormalities observed in individuals with schizophrenia, it would seem at the least somewhat likely that we can assume there's an immune component to the illness and likely to some of its treatments. This thought led to investigation of alternative treatment options. A number of approaches involving mitigation of inflammation and modulation of immune system have been investigated as therapies for schizophrenia, though with varying degrees of success. Types of these approaches include inflammatory agents like NSAIDs to stop or moderate an activated over-inflammatory process, agents that inhibit pro-inflammatory processes, and biological therapies specifically targeted at immune mediators and cytokines. Some NSAIDs investigated include aspirin and celecoxib. Aspirin irreversibly inhibits COX-1 and COX-2 and decreases synthesis of pro-inflammatory prostaglandins. Included in the top figure are 2 randomized controlled trials of the addition of 1,000 milligrams of aspirin given as adjunct to antipsychotics over 3 to 4 months to a total of 270 patients. Aspirin showed significantly lower negative symptom scores, but no overall change in cognition, which was another symptom area being investigated. The effect size for these 2 studies was found to be about 0.3. Celecoxib is an NSAID which specifically acts as a COX-2 inhibitor and inhibits the transformation of arachidonic acid to prostaglandins. And it's been investigated using 400 milligrams administered as an add-on to antipsychotics in 5 different randomized controlled trials with a total of 225 patients over 5 to 11 weeks. As can be seen in the table, there's quite a bit of difference between the results of the various studies. 2 showing some positive results, one of which was performed on first episode patients, with 2 studies being negative. Overall, there was found to be some improvement in total symptom scores and negative symptoms, but not in positive symptoms, with one of the studies finding no benefit in psychosis whatsoever. The 2014 meta-analysis from which this table was pulled shows a non-significant effect size for celecoxib of 0.15. Minocycline is an antibiotic that has been investigated as adjunct treatment in schizophrenia. It's a broad spectrum tetracycline that easily crosses the blood-brain barrier. It has antioxidant, anti-inflammatory, and anti-apoptotic actions. The table at the right, which has quite a bit of information in it, is from a 2017 meta-analysis of 8 randomized controlled trials with a total of like 550 patients. What it showed is, not very significant response for like positive symptoms with like modest gains in negative symptoms. This kind of improvement, however, was not replicated in a study from 2018 first episode patients called Benemin, which investigated minocycline's use for negative symptoms. Estrogen, as previously mentioned, kind of represents another modality of treatment. It has anti-inflammatory properties by ways of reducing TNF alpha and nitric oxide, which contributes to an overall reduction in oxidative stress. It's additionally known to have modulating effects on dopaminergic transmission. 7 studies included in the meta-analysis at the top, which is from the same 2014 paper, investigated estrogen's use in addition to standard treatment for schizophrenia. Of these, 6 of the studies included only females and 1 included only males. After removal of one of the studies, which had a very large effect size of 3.6, the analysis that was included in the table still demonstrated a significant effect of about 0.51. And the graph at the bottom is from a more recent study, as an 8-week randomized clinical controlled trial from 2019 involving 200 women of childbearing age, randomized to either receive placebo or estradiol patch. And it showed significant improvement in PANSS scores with use of estradiol. And a post hoc analysis of the study actually indicated an even marked improvement in individuals above the age of 38, with less benefits seen in younger women. The final approach we'll talk about is biologics, which represent a newer, more specified approach to treatment. Monoclonal antibody immunotherapy agents are designed to target specific immune receptors, and they can represent kind of an opportunity for more precise targeted treatment. This kind of a treatment approach for mental health conditions was first investigated in 2013 to target treatment-resistant depression via use of a TNF alpha antagonist infliximab. The study itself failed to demonstrate a generalized efficacy in treatment-resistant depression, though it was noted that patients who had high baseline inflammatory biomarkers characterized by a CRP of greater than 5 did exhibit some improvement in depressive symptoms. With regard to treatment of schizophrenia, the IL-6 antagonist tocilizumab has been investigated, first investigated in 2016, involving a small group of 6 stable patients, which demonstrated some improvement in cognition without an overall change in psychopathology, though it was noted that the patients included in that small study were quite stable. Another study from 2017 also looked at tocilizumab in a double-blind randomized controlled trial, and providing 3 monthly infusions over 12 weeks to 36 patients. Unfortunately, that study failed to demonstrate any improvements in like PAN scores or other neuropsychological testing. And one possible explanation for this, which was pointed out by the authors, could be that tocilizumab does not cross the blood-brain barrier, and there may be some that may be necessary for these kinds of treatments to have some sort of positive impact on individuals with psychotic disorders. So in conclusion, immune system dysfunction could represent a possible reason behind the ineffectiveness of our current therapies for a significant number of patients. And providing clozapine appropriately to those who need it can be a way to address current unmet needs for treating this population. Further investigation into the impacts of clozapine on the immune system and evaluation of existing drugs targeting specific components of the immune system could serve as an opportunity to fill other unmet needs and hopefully provide hope in better addressing this complex disorder. We want to say thanks to everyone at the Epicenter team and in the Department of Psychiatry and Behavioral Health for supporting our work and interest in this area, and included the evolution of Brutus picture. I'll kind of click through our references, but stop sharing the screen so we can answer any questions if there are.
Well, thank you, Craig and Walter, for a wonderful presentation here today. We'll try and sneak in a few questions if you guys are able to stick around here for a second.
Sure. Yeah. Sorry, it ran late.
No, that was the most comprehensive presentation of clozapine I've ever seen. That was awesome. And I say that even though I'm a little frightened about some of the earlier iterations of Brutus in the picture here there, where it was not quite well formed. So we've had a couple questions come in already in the chat, and I'll jump in with those right now. The first question is, given growing data about the safety profile of clozapine, has there been any consideration of relaxing or changing blood draw requirements associated with the medication?
I mean, from my understanding, I know a number of groups have submitted things to the FDA to try to get it off the REMS requirement, because like pretty much after a year, the risk of getting a granulocytosis is pretty minimal, and it's pretty comparable to other antipsychotics. And it's such a burden, you know, to have to do it. So like, I know they've submitted it. We'll see how the FDA responds, but I know they're trying to.
The next question that came in is, given the weight gain and metabolic side effects of clozapine, how is clozapine still able to reduce mortality among individuals with schizophrenia?
And that's obviously one of the great questions, like, because clozapine imposes such a burden. You know, you run the risk with like a variety of like physical problems you can have from it, acutely, like myocarditis, nephritis, ursitis, the immune cells, but then with the metabolic syndrome. So how I would probably view it is that it just because it works better, because it's a drug that tends to work better, that people are then able to kind of take better care of themselves, like follow up with like medical appointments, less likely to use substances. Also, clozapine is probably the best for decreasing like cigarette smoking, which is a big contributor. So kind of like you impose some risk, but it's like it's outweighed by like the salubrious effects of the drug itself and on the illness itself. Yeah, no, I think that was like that when that study came out in 2009. I think that was like shocking to everyone to see that Lancet study. But I think it just speaks to the fact that it's like better to use it. You know, people get scared to use it. People are scared that it's going to cause some problem. But when you look at the mortality data, is better overall in the grand scheme of things. It's the best thing to use if required.
The next question is, does the inhibition of CYP1AS also affect metabolism of other antipsychotics besides clozapine?
It does. I would say most predominantly olanzapine, which is also pretty significantly metabolized by that enzyme. There's probably, off the top of my head, I don't know of any other significant interactions, but there probably are some where it's like less of a major pathway for metabolism. But
Is Halo 1A2?
Halo's 2D6, I'm pretty sure. But yeah, I would say olanzapine and olanzapine, Seroquel, or quetiapine, and clozapine are three that are I'm confident that it has action. So inhibition would be a problem.
And that's one of the problems, is that clozapine and olanzapine are probably the two strongest agents. Really rarely only come in like oral form. And because it's all 1A2, the biggest impact on 1A2 for a lot of people is cigarette smoking can induce 1A2 like 30, 40, 50%. So you can take someone's levels down of the drug a decent amount from cigarette smoking. And so a lot of times people are in the hospital where you can't smoke, get better on a medicine, and they go out and they start smoking again. Those levels can be dropped pretty appreciably. So it's pretty, a lot of the other ones, like there's a lot of like drug interactions, but the ones of like just like kind of everyday things people do, 1A2 is probably one of the trickiest ones because of the smoking.
Great. Well, that brings us to the end of our questions here. So thank you both for a wonderful presentation. Thanks everyone for joining us today. We hope you'll be able to join us for our future presentations here at our speaker series. So hope everyone is staying well and healthy. And Walter and Craig, thanks again for a wonderful presentation today.
You're welcome. Thanks.
Bye, everyone.